feeling well. So anyway, we're just going to get started now. We have a couple of people here with us today, just a small group, and Dr. Santa Maria is going to be answering all of your questions.
No.
No.
Not all your questions?
Not all of your questions, some of your questions. I'm going to hand it over to him now as you can follow along on the screen. There is a PowerPoint with some pictures and slides in it, and here we go.
Okay, so welcome everybody. Dr. Santa Maria here. Many of you know from seeing me online and previous webinars. I'm internal medicine doctor in Boca Raton, Florida. I'm interested in POTS and dysautonomia for quite a few years, and have tried to educate myself as much as possible in this field, and therefore help as many people as I can, passing on the knowledge. Today is supposed to be an advanced seminar, not basic POTS. So if you don't know anything about POTS whatsoever, wondering, do I have it or how's it diagnosed, the simple stuff, I'm going to say, look it up. I'm going to say that a lot today because, you know, this was my chance to talk about some advanced things that I think that people who have had POTS for a while or had dysautonomia and have been to numerous doctors can think a little more deeply about, you know, the causes, associations, and the evolving symptoms. Like I said, I'm educating myself as I go along, and I'm hoping that you POTS patients will in turn educate others, because I think that's a critical role. I think you need to educate your physicians, your family members, and if anybody gets referred to, oh, I know a girl who has POTS or a guy who has POTS, could they talk to you? Or, you know, I have somebody who might have it. Would you mind talking to them? I want you to talk to them, educate them, and help them to be, bring them along, share your knowledge and, you know, the things you've learned, so you can become educators, and that in turn will help you too, the way it helps me. You know, just to give you a little insight into doctor's psychology, because you're all dealing with doctors all the time, you know, when we graduate from medical school, one thing they always say at your graduation is, most everything we've taught you will be obsolete within 5 years.
Huh.
That's a standard speaker's line from graduation ceremony, and it's true. So what they're trying to say to you is, we've given you some constructs and some outlines, fill in with lifelong learning. You know, go out there, learn new things, advance the field, and don't rigidly adhere to that's the way we've always done it, or that's the way it used to be, or, you know, I know all there is to know about that, and don't confuse me with the facts. So, as many of you have seen already, that, you know, basically that leads to two different kinds of doctors. You know, doctors you have to see and doctors you want to see. The doctors you want to see are the people who are inquiring and interested and trying to further their own education. The ones you have to see might be on your health plan or on in your neighborhood or whatever, and they may not care about what you've got, or what, you know, or want to spend time on it, or really be dealing with a patient who's very high maintenance, as we say here in Boca. So too bad. Find someone who is, you know, and use the online resources and the forums and the webinars and etc. Like I said, sometimes you just have to be your own advocate, your own doctor, and I'm highly in favor of that. When patients come to me with material and online, and I saw this and I saw that, I say, really, where? Let me see that. You know, I'll go check it out. And then I can analyze things scientifically, and I'll look at studies or papers, and I'll see if they're flawed or if they're valid or if it advances the science or if it's just somebody's hunch. But, you know, by these kinds of fits and starts and 2 steps ahead, 1 step back, that's how we all make it. So I was also thinking on the way over here, I never watched Survivor, but this POTS thing and life in general is sort of like a game of Survivor, I guess, right? They give you a set of circumstances and an island, and you try to figure out how to survive it and get through it. And that's kind of what we're doing here. So as soon as you say, well, I have this and I have that, but I'm, you know, I have other skills or intelligent, intelligence or ability, and you work with it, the less resistance you'll feel, and that alone will help you. So I hope that we can talk about some things here that can help you further your knowledge. You know, a lot of times I'll be saying, I don't know, or I wonder, and that's Dr. E's for, you know, nobody knows the exact answer to that question, but we need to find out. Or that's what they're studying at Vanderbilt or Mayo or Grubb or Boca Raton or whatever, you know. We don't have all the answers. So sometimes things will come up and we'll just wonder. Which to me is the excitement. That's why I go back every day, because, you know, to me, it's like a page-turning novel. I want to see what happens next. I want to see what the next chapter is. And in the process, hopefully, people will feel better and function better, and that's that. So.
All right. So before the meeting, we were able to collect some questions via email, and so we're going to start by taking a look at the first slide here, which we've done a blog on before on the website in regards to why do people with POTS get shortness of breath?
Right. Well, as I said to you many times, people with POTS are people, and people, you know, can get any array of illnesses, and shortness of breath, you know, has a differential diagnosis. I guess we should start by saying that, you know, you say, I'm short of breath, that's a symptom. You tell me you feel like you're not getting enough air. I look at you, I can measure certain things like your oxygen saturation when you walk. Those are signs. We call that DOE, or dyspnea on exertion. People are also dyspneic or short of breath at rest. Obviously, things like asthma and heart failure can cause difficulty breathing. I put a slide on here. Let's see if it made it to the. I wanted to speak real quickly about ventilation perfusion defects. You'll have to look that up yourself, but I will tell you what it is. Ventilation perfusion means, in lung physiology, air goes in your bronchial tube, down the tree, out to the periphery, and there it meets up with blood vessels that are coming by. The blood vessels have low oxygen. They pick up the oxygen, they go back to the heart and get pumped out to the body with freshly oxygenated blood. So if the blood is going by areas where the bronchial tubes are blocked from mucus or emphysema or destruction or plugging, then there's no fresh air. That blood is going to return to the heart with no oxygen. If, on the other hand, there's a wide open bronchial tree and there's not blood flow going to a certain segment of your lung for whatever reason, pulmonary embolism, POTS, orthostasis, that air is wasted because it's getting down there and no blood is coming by to pick it up. So that would be a perfusion defect. Ventilation means, you know, the air is not getting down here. Perfusion means the blood is not going by the airways to pick up the oxygen. So ventilation perfusion defects are a huge part of medicine and why people feel short of breath.
Question?
So,
yeah. Can I ask a question? Would niacin help that to open up the?
Well, it depends on the cause, right? My question again, here's where I wonder if there's lung orthostasis. Okay, so you know that you have venous pooling in the bottom of your body. When you stand up, blood is down here. It's not returning to the heart, right? If the same thing is happening in the lungs, then you're getting areas of lungs which are getting fresh air, but no blood is going to them. That would be a ventilation perfusion mismatch. So I haven't been able to find any papers or studies documenting perfusion of the lungs in POTS patients or dysautonomia, but let's face it, it's an automatic system function, right? So
I noticed too, and someone just said in the chat that when their daughter talks a lot, she gets shortness of breath, and
right.
And I get that all the time. Like I'll just go and go and go, and then at the end of it, I can't. It's like I can't remember my breathing pattern.
Right. We talked about this last time. I think that falls under the heading of Valsalva. If you remember, we talked about breathing out against a forced resistance. So if you're blowing up a balloon is probably a great example. You want to blow up a balloon, you probably pass out,
Yeah.
right? You will be so short of breath. Why? Because the increased intrathoracic pressure keeps the blood even more down here. So when you're talking, you know, blood is similarly being impeded from making it into the thoracic cavity. So you probably have just aggravated an already diminished venous return. So your cardiac output is worse. Again, back to what I just said about ventilation, perfusion, mismatching. You talk, blood stays down here. There's not so much blood to pick up the fresh oxygen, get back to the heart. This is why, you know, the lungs, you may think of it as kind of a dumb, you know, situation or something you just ignore. But the lungs have a very intricate sympathetic, parasympathetic nervous pattern. You know, for instance, if you lay on your back, you know, the air you're taking in is going to the lung segments on top. If you lay on your side, it's going here. You know, if you lay on the other side, it's going here. So it's very distributed based on your position. Some segments will collapse, some segments will expand. And that's fine if you can immediately shunt the blood from one area to the other. Let's say I flip over in bed to this side and all the air is going up here. That blood better go up here too.
Yeah.
Quickly. Because if it's still going down here, it's coming back to the heart with no oxygen.
So if you're talking too much and you can't breathe, what I mean?
Blood is probably staying down below.
So what do you do? Should you like move around?
Don't
like,
talk.
Don't talk.
And walk.
Stop talking. Okay.
No, talking and walking is the worst, right?
Yes.
Yeah.
But even if she doesn't talk and walk, she's
Just sitting and talking.
Yeah.
talking, she'll run out of the breath.
Well, you have to be aware of your breathing.
Yeah.
I mean, let's face
She'll
it.
do that big.
Yeah, you have to do that. You have to ventilate more. Because when you're not ventilating deeply, what's happening? What I just said again.
Yeah.
Right? Remember, lung segments are collapsed, what we call atelectasis. In other words, just like a bellows, they're not being expanded at all. So if I only take a breath, you know, it takes about 150 cc's of air to fill up just this much of the bronchial tree. So if I take a little breath like this, all I've done is move this air. I didn't move this air at all, right?
Yeah.
So when you go to the doctor and he says, all right, I'm going to listen to your lungs, take some nice deep breaths through your, and I'm listening way down here. That's the only way I'm going to hear any air movement. If you move a lot of air, that expands these segments, right?
I'm not able to do that without pretty much passing out.
Take deep breaths or?
Taking the deep breaths. And I even have a hard time breathing sitting up. I can't take deep breaths. Because the second I start doing it, I start getting so dizzy and pretty much passing out.
Right. So now we're getting into acid-base disorders, you know, carbon dioxide, bicarbonate.
You can hear me,
I
but
can hear
I'm
it in your
struggling
Yes.
right now.
Yes. Yes, and some people have, right, like I said, they have limited perfusion and they have acid base. Like all of us know that if we hyperventilate purposely, if we go, we're blowing off a lot of carbon dioxide rapidly, we're going to get lightheaded because we just blew off all that carbon dioxide. We're going to get acidotic and etc. That's, you know,
So the niacin,
that's something you
niacin
can
would
do.
help it.
Niacin is not specific enough for, you know, dilating those vessels. Now I don't know what is. I'm just these are thoughts that I have. I'm trying to be a little bit like cutting edge here today because there are things you can read about, and you know, and there are things you can think about. And this is what I'm thinking about. Why are you all having these problems? Again, so acid-base disorders, blood flow back to the lungs. Those are things
When I
that.
walk, it's almost like my brain can't figure out how to do both at the same time. So by the time I get, like when I came in, I was like,
Right. So what she's saying is, when she's walking, it's she has to actually concentrate consciously on breathing and moving, which all should be automatic
That is totally
or
POTS.
autonomic.
That is totally, you know.
but yet they told me I don't have POTS. Like one tilt table showed POTS and one tilt table showed I didn't have POTS. So it's
Okay. So, but you know, you have an autonomic nervous system dysfunction. Let's just leave it at that.
Yeah.
We don't have to over pigeonhole here because, again, you know, with medicine, as what I've seen just in my career, is we've gone totally from a symptom and sign driven medicine to genomics, biochemical, machines, tracings. In other words, if someone, when I started, if you were hypothyroid, we had to wait until you had a slow voice and your skin was all dried up and and you were sluggish. Say, wow, this person's hypothyroid. Now we got blood tests and other tests. We can diagnose that quick. Same with POTS. We have getting sophisticated tests for dysautonomia. 15 years ago, they didn't have a lot of the things that, they'd say, well, you have to fail a tilt table test, or well, you this. So, and I think as long as you brought up tilt table test and upright posture, we should talk about POTS and IST is something I want to differentiate a little bit here. The tachycardia, which become known as inappropriate sinus tachycardia, versus postural orthostatic tachycardia. Are they one and the same? Are they a spectrum? Of course, they're a spectrum of dysautonomia. That should be obvious, so we don't want to over pigeonhole. But strictly speaking, if you want to get a diagnosis of POTS, you have to fail a tilt table test. What does that mean? They put you upright, your blood pressure has to stay relatively the same, your heart rate has to go up 30 beats. Okay, that's the criteria. When you're sitting down, minding your own business, your blood pressure should be about the same, and your heart rate should be normal. Normal is 70, 80 beats a minute. Well, there are people whose heart rates go all over the place when they're sitting down, lying down. Doesn't matter what they're doing. They can go 142, they can go 90, they can go 50. So it's not because they're orthostatic. They've stood up and now their heart rate goes up, which is POTS. But they rather have a sinus node, which is the heart's own pacemaker, which is acting very erratically. Suddenly the heart's going 110 or 20 beats a minute for no reason that we know of. Then it's going slow. And that inappropriate sinus tachycardia is a form of dysautonomia also. So all should be under the same general heading. And but some doctors are still hung up on the, pigeonholing. You have this POTS, you don't have POTS, you have hyperadrenal, you don't, you have dysautonomia, you don't. Whereas we know that people's heart rates don't suddenly go to 110, 12 while they're just laying in bed for no reason, or they stand up and their heart rate goes up, or they stand up and eventually their blood pressure and heart rate drop out, which is another, variation of dysautonomia, neurocardiogenic syncope. So it's all spectrums of dysautonomic. We're talking, I also wanted to talk about the link between diabetes.
Hold on. Let's
I can't talk about that?
We'll talk about that, but let's go through it.
You want to continue on what we're doing here?
Yes. So, because there's a lot of questions, and at the end we have 2 slides on that, so we want to show them the figures and everything.
All right, go ahead.
Okay, so we had a couple questions on burning sensation and adrenaline rushes. And can you explain burning sensations accompanied by adrenaline rushes or burning in the hands and feet?
Well, this brings up the topic of small fiber neuropathy, which is, did you put the small fiber neuropathy slide up there, though? This slide? No, sadly.
Yeah.
Okay. So,
But you can grab it right now and put it on there.
yeah, if you can do that, that would be great.
Yeah.
The in the nervous system, we have different kinds of nerve fibers. Obviously, there's motor nerves. There's large nerves, small nerves. The small nerves are typically part of the autonomic nervous system. They have automatic functions. They control things at your skin level and in your internal organs. We just talked about sinus tachycardia, inappropriate, the heart rate being controlled by the fibers. The peripheral small nerve fibers control things like pain, burning, cold, creeping sensations, and things like that. So there seems to be, and also sweating, I should mention, because that's a basic test for small fiber neuropathy. So the bottom line is that small nerve fibers that are attached to sensors in the skin and that area pick up and control sensations, and can be dysfunctional, can be damaged in autonomic neuropathy. There is a test called QSART and some other tests that test for your ability to sweat appropriately. So that's a way to diagnose whether you have small fiber neuropathy. Let's face it, if you have burning pain in your hands or feet, if you have extreme cold when it's not cold, or extreme heat when it's not hot, or tingling, or you feel like ants are crawling on you when they're not, all of those things are dysfunctional small fiber symptoms. So the small fibers pick up sensation, transmit it to the brain via the sympathetic ganglion, and can be damaged as part of the whole spectrum of dysautonomia. Now, I guess a logical follow-up question would be, what causes damage to the small fibers, small fiber neuropathy? There are some specific associations. Sometimes we know clearly there's a relationship, and I think we should mention some of those things. I mean, actually, we just mentioned that it's typically seen as a part of the spectrum of autonomic neuropathy, dysautonomia, whatever that means. Is this on their screen now?
Not just yet.
Okay.
It will be in a minute.
It's also associated with things like diabetes. It's associated, which is a form of sugar poisoning, I guess, if you will. It's associated with other poisonings. Typical, we see it after chemotherapy. We see it in alcoholics. And it's associated with some autoimmune disorders, Sjogren's disease, lupus, Lyme disease. There are many conditions like that, amyloidosis, where we see an association commonly with small fiber neuropathy. Is it autoimmune? Is it toxicity to the nerves? Is it all of the above? Yes, because frankly, you will see when you look at small fiber neuropathy that most of the cases are carried as idiopathic, meaning cause undeterminate. We know you have the neuropathy. We can test for it, or you can just tell us what you've got, and we pretty much know you've got burning, tingling, cold, ants crawling, feeling in your hands and feet. That's small fiber neuropathy. How did you get it? Sometimes we'll be able to tell, and sometimes we won't be able to tell. So how do we treat it? That's a tough one. No one, I mean, obviously we treat if there's an underlying disease, we treat the underlying disease and hope it goes away, and that often happens. I've seen many cases of diabetic peripheral neuropathy reverse or subside with various treatments. One thing that's worked great for diabetic neuropathy in my practice is phenphotiamine. Let me spell that out for you. That's benfotiamine. Phenphotiamine is a form of, sort of a super form of thiamine, which is vitamin B1. The vitamin B1 is critical in nerve functioning, and sometimes the benfotiamine helps diabetic neuropathy and perhaps other neuropathies. Also seen ALA work, alpha lipoic acid, in high doses like 600 milligrams twice a day. And vitamin B6, I've used that in neuropathies in doses of about 50 or 100 milligrams a day. Some people have experimented with intravenous immunoglobulin, plasmapheresis, on the off chance that that'll clear something, but they're not always sure what exactly they're treating. There's also anodyne therapy. If you have a localized case, burning feet or something, you can do anodyne, which is a low-level laser, LLL, low-level laser treatment. So you take a laser which is of certain spectrum and has a certain penetrance and shine it on tissues, it will sometimes heal or reverse those kinds of conditions. So there's actually a machine called anodyne that's used on feet because that's where small fiber neuropathy typically occurs. Obviously, it's not good for other areas of the body, but if it's superficial and hands or feet, low-level laser might help too. So that's why people feel is the key word here, because those are sensory nerves that conduct sensations like, as this person asked, my burning or excessive cold or heat, or I don't sweat or I sweat too much. Those are all variations of small fiber neuropathy.
And the image is up on your screen now, so you all should be able to see.
Okay, so if you can see that, you'll see that the small fiber is reaches the skin, as I mentioned. At the bottom is a cross-sectional skin biopsy. In the normal skin, you can see how the terminal filaments of the small fiber there, how they go up into the skin. And then they have a variety of specialized receptors that can feel pressure or temperature or strain or heat or whatever, and they conduct those impulses. And on the right, you can see somebody with small fiber neuropathy who is missing those fibers completely, and we don't know how they got there. Like I said, could have been chemotherapy, alcohol toxicity, idiopathic / dysautonomia. But the point is, this is one way to diagnose small fiber neuropathy. You can get a skin biopsy, and a pathologist who's appropriately sophisticated to do a stain like we see here in the slide. And as you can see, those nerves are very tiny and difficult to see even at best. But that's one way to make the diagnosis. Other ways include that we mentioned QSART and sweat test and what have you. So that small fiber neuropathy is often part of the spectrum. And as we all know, because this is advanced class, the spectrum evolves over time. One point of your life, you might have terrific neuropathy. Another part might be migraine. Another part may be gastrointestinal. Another part may be tachycardias or all of the above. So we try to deal with these things as they come along.
What about blood pooling? Can you explain blood pooling and why, and like when it is and isn't dangerous? Or
well, we talked about blood pooling a little bit. Blood pools with gravity. We alluded to that earlier. Gravity is what makes blood pool, and so the capacitance vessels have to be able to respond to that. What does that mean? If you stand up, we all have about 500 cc's, or about 1/10 of our blood volume goes down into the legs and abdomen. So that blood isn't coming back to the heart, so the heart has to compensate. Heart has to compensate by increasing the rate a little bit, the strength of contraction a little bit, and constricting the blood vessels on the other side so that the pressure stays the same with less volume. So less volume coming back, vessels have to get a little tighter, heart has to go a little bit faster, pump a little harder, and everything stays the same. So you can go from lying down on the ground to jumping up and blocking a shot on goal without even thinking about it. If you're a goalie without odds. If you're not, things just don't equilibrate that quickly. So the question is, in POTS, strictly speaking, which is orthostatic tachycardia, if the blood is pooling down below, which it does in all of us, but the heart and baroreceptors aren't responding appropriately, you will feel either the tachycardia or the lightheadedness or what have you. And that's because the cardiac output is not maintained. Cardiac output is the volume of blood that your heart pumps per minute, and that's a function of your heart rate and stroke volume. So if your heart pumps 70 cc's of blood per stroke times 70 beats a minute, that's 4,900 cc's of blood, or 5 liters per minute cardiac output. That's standard for all of us. But if the blood's down here, something else has, your heart has to compensate some other way. So we're all, you all anyway, are used to the fact that if you stand too long, you may pass out or get close to it. If you wear compression garments that force the blood back up toward the heart, around your legs and abdomen, and Under Armour now has stuff that'll go all the way up to your nose, blood will come back more effectively. And that's what that's all about. So compressing externally
I think we talked about
prevents
that
the blood from pooling.
in the last one about how there's more than just compression stockings. There's like
Compression garments now. Yeah, and they're getting pretty popular.
Abdominal stuff and
Mm-hmm.
arm ones. You can just put
Right,
yourself
there's
in a
whole
giant
suits, right.
stocking. Yeah.
Recharge suit, they call it. They got clever names for
G-suits.
them.
G-suits?
Yeah, they used to be big, clunky, stupid Air Force things with hoses coming out of them and everything. But now, like Under Armour and some are making them a little bit fashionable and high-tech fabrics, and they conform to your skin, and the heat, they wick water and
Can
heat.
you wear one for us the next
I will, yes,
Great.
sure.
fashion show?
Why not? So that's something you can consider. In Florida, that's a tough option because it's hot here.
Yeah.
But up north, I would think that would be a great option because it's like we used to wear, what do we call it?
Or underwear?
Long underwear,
Long johns.
thermal,
Long johns,
long
yeah.
johns, whatever you call it. We used to do that. So just buy something that's compression and wear that. And
All right.
that'll help. That'll form a couple of functions.
So what about connective tissue diseases in POTS? Things like EDS and Ehlers-Danlos syndrome and Marfan syndrome and
JHS, the joint hypermobility, sort of connective tissue in general. I think briefly, we all know that there are associations. Again, because it's advanced class, associations don't explain cause and effect. Unfortunately, there's some potential cause and effect. Marfan syndrome, for instance, which is a particular type of connective tissue weakness, they get joint hypermobility. They also get abnormalities of things like the connective tissue that holds the heart valves in place, that those rings get lax and fail, and the heart valves fail, and that's an extreme
Marfan
type.
is people who are, isn't that really tall?
Connective tissue disease. Well, they're
Abe
tall
Lincoln.
because
Abe Lincoln.
Abe Lincoln.
right. There's many Marfanoids out there, and they don't always
Marfan.
last too long. But then there are connective tissues, or Ehlers-Danlos forms that make for small stature, small bones, small. There are normal-sized people with hypermobility, and do you have?
I have a question. At what age can you test for EDS? Because a friend of mine has EDS, and she was messing around with my son who was 4, and he goes, "Oh, I can do that." And then he started doing everything she can do. So I was like,
Well, that is the test.
I was
Yeah.
like, he's 4, so I was just like, I brushed it off. He's 4.
Yeah.
He's young. But I started getting concerned because he does bruise very, very easily.
So her question was that her son at 4 years old seems to be showing hypermobility of joints that might be out of keeping for just a 4-year-old. He can bend his wrist and thumb and et cetera, just like her friend who has Ehlers-Danlos. And, she said, how do I test for it? I said, well, that is the test for it. The test is mainly clinical. Yes, we're working on collagen biopsies and genetic tests, but it still comes back to in the clinic, can you do this? Can you put your hand backward? That hurts me just thinking about it. But
I can do some of it, but I can't do all of it.
right, so obviously that's joint hypermobility by definition. Now,
But
is
not
that
everybody has joint hypermobility.
Yeah.
Like if you look
Of
at
course,
surface to
right.
leg,
So that's why I keep
everybody
thinking
can do that in surface to leg.
he's 4. So
right? So the question is a person with joint hypermobility going to have other dissociated diseases? Of course not. It's not guaranteed. It's just high association. We're looking for things that have high association. So if you have Ehlers-Danlos or joint hypermobility or Marfan, are you more likely to have? Yes, you are. But do you have to have? No, of course not. But I would watch them for signs of dysautonomia and the various manifestations, which we know sometimes it takes years to put all this together. You might have had migraines only as a child, and eventually someone says, oh my God, that was, the precursor to Chiari, or that was intracranial hypertension, or that was, the forerunner to POTS or something. So horizontal history is important. That's what I do, as an internist. I see people over long periods of time and try to integrate their history into a storyline. Whereas, when you go to a specialist, you travel to a place, sometimes they try to hear your history, make a pronouncement, give you direction, and then send you on your way. Both things are valuable, and I value their input so that I can help the person on a long-term basis. But, it takes working together.
So if you suspect that you have small fiber neuropathy or you have a connective tissue disease, what kind of doctor should you go to get tested? Is it a rheumatologist? Is it an internist? Is it...
The small fiber neuropathy, if you go to a neurologist, remember it's neuropathy, so your inclination is going to be go to neurologist. They're going to do an EMG and nerve conduction velocity, EMG and NCV on you, which is going to be normal. Mm-hmm. Because those things test large motor function. Large nerve function, and the large nerves control things like muscle movement and vibratory sensation, but don't control what we're talking about here. So a normal EMG and NCV would be a precursor to the diagnosis. If he really wants to make the diagnosis, he would have to do a skin biopsy, so we'd have to send you in turn to a dermatologist, or at least a surgeon who can do a decent skin biopsy, get it to a pathologist who can do this kind of procedure. And, ultimately you're going to come right back to what you knew clinically. And that, that's another thing I wanted to say today. Use your common sense. That's what I do. I use my common sense. I take the history, I ask for the facts, I examine the person, ask what, and by the time I've gone through their history, their exam, their meds, everything else, I usually have got the diagnosis. I've put my head together, and I put the case together, and wow, you got small fiber neuropathy. It wasn't long ago, I told somebody that, and they had to go to Mayo, and they spent days there getting biopsies and tests, and they came back, and I looked at the report. I flipped to the last page because I'm cheating. And it says small fiber neuropathy, idiopathic. And I said, wow, I told you that for for $50 in here in Boca Raton, but whatever. Furthers the research, the wonders of research and the data, but it doesn't help you. So you come back and you say, okay, so now I got this diagnosis. What do I do? Well, I just told you what you could do.
Well, so, yeah, this is the thing. Someone's asking. I understand what you were saying about using common sense, but don't you need a doctor to help treat the small fiber neuropathy? But that's,
I should have said a doctor with common sense.
Yeah. Well, what we tend to notice is that all of these patients, they know that they have POTS after a certain while, and then they feel like they have to go to Mayo or Cleveland or whatever.
It's part of the rite of passage.
Right. It's
the rite of passage.
Yeah,
absolutely.
they go for days and they get all these tests. But what ends up happening is that these institutions are there more for testing and for collecting of data and research, and not for treating. So it is not the place to go for treatment. It is the place to go for diagnosis.
Absolutely, but I think that all of you have to realize that you're part of a human swell of history. How did we know? Yeah. How did we learn to treat cancer and heart disease? Think of all the people who lived and died and went through those trials and didn't get the active treatment, or got the surgery that ended up being a mistake. And
everyone is
that's how we treat people now. But you're not thinking about those people that came before. Like I said, they gave their lives for the advancement of science. I'm not saying you should go give your life for the advancement of science.
Yeah, don't do that.
If you can contribute somehow, I think if you think about it as a contribution, that's a great T-shirt. I wish we had that. Dysautonomia sweatshirt. Where'd that come from?
A girl
Did
in
you
the-
make that?
No, I wish. I've made a couple T-shirts actually in a
That's
bag.
great.
I have.
Oh man, I
That's
like
awesome.
A girl in another group made it.
Oh.
Sent it to me.
That's clever.
That's cool.
But
Okay.
yes, you're adding to the basis, and this is where where I get most of my information. I don't do research. I don't have thousands of people streaming through my office, filling out questionnaires and taking histories.
Although
and,
we'd like to do that.
Well, I'm not set up for that. I have to treat people day to day to day to day because who's gonna, do that?
So dysautonomia associations do that? Do they?
Dysautonomia associations, they're there to collect money to research and to distribute information on dysautonomia.
Which is great. I mean, we
Wait,
need
at Vanderbilt?
research, right?
At Vanderbilt?
Probably.
Yeah.
Yeah.
Those guys need they need equipment, they need techs, they need support of all kinds. They need to keep doing what they're doing, and God bless them. I hope that they find answers to actual, and they're coming with it. I mean, this whole sympathetic nervous system.
It's interesting, they're saying it sounds like you're the doctor to go to when your own doctor or cardiologist isn't doing enough in terms of treatment. And I think that the large complaint of the community is that everybody who's got a doctor and finds out they have POTS realizes that their doctor doesn't really, they know of one or two or three maybe medications and then give up on them.
Can your
It's
doctors reach out to you?
Sure, absolutely. I've talked to other doctors numerous times. They say, my patient, we have a common patient. They have this. What do you do about that? Or what do you suggest? And I do the same thing. I'll call the electrophysiologist and say, anything else I can do here? Or what else? Because that's how I further my knowledge base. And we're sharing knowledge too. That's how we get better, And if something new comes along that's worth knowing about, definitely. But it is a problem because care is fragmented for all chronic illnesses. Let's face it, you go to a gastroenterologist or a neurologist or a this, that, and the other ologist, and they are the right hand, the left hand may not know what they're doing all the time.
Yeah.
And sometimes you have to be a treating doc, you just have to jump in there and try something. A lot of this is trial and error.
Yeah. I think people think that the journey kind of ends once they get diagnosed, but that's really just where it begins. Once you get diagnosed, it's a matter of
Self-education,
Yeah.
educating your healthcare providers
And
if they
unfortunately,
need it or
everyone
open to it.
every POTS patient seems to be different in terms of symptoms and, chemistry of medication. So it is all.
In this healthcare environment, it's a strange paradox I'm seeing right now because I've been in practice for years, but if I look at, let's just say 10 years, the pressure to see more and more and more patients is growing astronomically. Therefore, the time allotted to each person is diminishing.
Mm-hmm.
At the same time, the knowledge base for all of these conditions is exploding. So you get a patient with a complicated set of symptoms and signs and tests and medicines, and that's expanding every day, and multiply that times 2,000 or 3,000 that you have to take care of. That's a mind-boggling proposition. When you're supposed to see, I used to think 18 people a day was a big load, and then 22, 24, 28, 32, 38. People are seeing 35 people a day. What? How can you possibly do that? Just break that down into human endurance and think about how much focus and time, and at the same time, the phone's ringing, nurses are knocking on the doors, people in the room, so-and-so's on the phone, the emergency room wants you. I mean, and then once you're out the door, how can I think about everything you said or everything that might be wrong with you or everything I wanted to do? Because now 50 more people have come to take your place. It's really like I said, it's a strange time in medicine. I'm not sure how it's going to all work out. But so I, as you know, have gone to the concierge model because I could not tolerate that kind of pace anymore because I just said to myself, I'm not doing anybody any good. I'm not doing myself any good. I need to get some people, focus on their problems, keep it in-house, and so I'll sit for an hour and ask questions and take stories and think of things. And when we try something, people will email me or come in short interval, and we'll say, okay, that didn't work, or that's working great. Let's try it. Let's do some more. That interacted with this. Okay, that's no good. Write it down. But how are you going to do that if you're in a normal practice? I just can't imagine.
And that's why doctors too, I think when you bring in research to them and they're like, oh no, you want me to read something inside of the span of the 4 minutes that I'm allowed to have with you.
Like they're insulted.
Yes.
And I know after my lumbar puncture, I had a horrible reaction to it, and I was ended up hospitalized twice from it, and I still have spinal headaches.
Yeah, she's saying the doctors almost put out when you have a problem or a complication or an extra question because they either feel offended. I don't think it's so much offended as it's just like, another thing,
Frustrated.
I can't take one more thing, or.
I know,
And
bringing up more questions during my visits at Cleveland
Yeah,
Clinic,
yeah.
it was just, well, no, it's like if you bring up ideas to the doctors, well, it couldn't possibly be that. It couldn't
Yeah,
possibly
yeah.
be that.
She's saying
There's
just
a
to
doctor
recap that when
Yeah.
she goes to Cleveland Clinic and she brings up questions,
It couldn't possibly be this.
it couldn't,
They get
it couldn't
frustrated
possibly be this, it couldn't possibly be that, and the doctors get frustrated. And
So that's this is the difficult paradox here. If I concentrate only on people like her, whatever question she's going to ask me, no problem, I can handle it. But then I'm restricted to only that practice. Now, if I want to have a general internal medicine practice, let's say, for instance, or even general cardiology practice, I've got to take 50 or 100 different equally complicated situations and deal with them one after another as they come filing through the door and switch my mind right away. Oh, that's atrial fibrillation, that's POTS, that's this, that's SVT, It's a tough business. And I understand everybody has got, you're living in here and you got, your problems and things you have to deal with. The doctors have, empathy, but
don't have time.
so much is coming at them. It's like, it's just like,
So what can we do?
Right.
So what can we do as patients?
what can we do as patients
That's it.
So
I'm
let's
still
all
wondering
find
as a
out-
doctor
Yeah.
to,
To
I mean, the
prepare.
concierge thing is great, so you can spend time, never rushed and never fluff you off. When you're in medical school, just to back up one step, the idea is you're supposed to have patients that are yours on the ward, and you follow them. They assign you as they come in. You're the medical student. You work with the intern. So I have a person with congestive heart failure, and I have a person with pancreatic cancer, and I have a person with whatever. You're supposed to go home and read about those things constantly, all day, because then you come back next day. Here's a person with it, and then that's how you learn, You see it, you read about it, you study it, and there's another one, and pretty soon you incorporate it. How can they learn all kinds of new things all the time in the midst of a busy practice? That's tough. Like I said, that's why I think you need to be self-educated. But how to get through to the doctor?
What about video
Ugh.
bites? Like you're giving us now a lot of information.
Yeah.
In an hour or 2 hour thing.
Well-
But video bites for the different things like the neuropathy.
What about a clip?
the
Yeah, a quick
shortness of
clip.
breath. So if we
Yeah.
could have Dr. Santa Maria, like in these things, cut them up in little video bites so that when you walk into a doctor's office, you're going to show him a 3 to 5 minute video and say, look, this is what I'm dealing with. This is the
That's way too much. It's way too much.
Yeah.
So what we've been working on, but we have thought about this.
That
and
is, it's a great idea, but
Yeah.
it doesn't.
The videos are I think it's going to be too much. But what we have been working on is resource sheets that we're going to be having available on the website probably this week. That will have sheets that you can take into the emergency room that quickly give you the bullet points of what POTS is and how you treat it, as well as things like what saline therapy is and how it should be prescribed, and what it does to the body, and bullet points for doctors so that
But a lot of it comes back to the doctor's personality. When
Yeah.
someone walks into my office
Do you
with that, I
wanna
go,
learn
let
or
me
not?
see that.
Yeah.
Yeah, that's great. Okay, boom, cut right to the chase. I just saved myself going on the internet and, oh, wonderful. Other people like, what is the hell is POTS? Forget that. That's a great cartoon online. No, forget it. It doesn't exist. You don't have it. You're a pain in the ass. You're a drug seeker. You're
Yeah, you
yeah.
got
Well, in the ER you can't do
Five
that. That's why I said.
That is something personally, I don't mean to interrupt.
Yeah.
that
No, I had.
I experienced after, again, my lumbar puncture.
Yeah.
I was rushed to the hospital
Right.
for my spinal headache. ER doctors had no idea what to do with me.
Right.
They tried to give me
Worthless.
morphine, which I had a horrible reaction to. I ended up walking out of the ER.
Right. A lot of ER docs are just, yeah, like we said, are inundated.
Yeah,
And
I called the directors and I went into them. I said, you know, you could have killed me giving me morphine.
Right.
You know,
She's saying that she had
worked
a
with the medical
lumbar
director
puncture
of the
and had a
hospital
bad
and the
reaction
ER
to it,
directors.
and she
I
went
sent
to the
them all
emergency
of the
room, and
information online,
Yeah.
like dysautonomia and
the
POTS,
doctors
and
wouldn't listen
they
to
are
her, gave
now
her
on a
morphine, she had a
special
bad
card.
reaction, she ended up walking
Anywhere
out of the
in Polk
ER.
County, they will airlift me or my ambulance to Wellington because they are now my hospital to treat me. Because
I mean,
my education
that's
And she
great
spoke with
for
the
you, but-
directors of the hospital and
Right.
made sure that she only goes to
Right,
certain
exactly.
hospitals when she's having an emergency with doctors that she knows and who understand her condition.
The administrator.
The administrator.
That's the way to go.
And the medical director.
So
Mhm.
she's saying if you're in the hospital and you're having a situation, the one you want to contact is
The ER director and the administrator.
the ER director and the administrator. And how can you get their information?
I just
But the best time to, let me interject, the best time to do that is when you're not sick.
Yeah,
Don't expect to go in there sick
no.
and talk to these people. Go in when you're not sick.
yeah.
So that takes some planning. If you know you're going to frequently be in a certain walk-in clinic or a certain emergency room, and you may have to resort to that, go educate them while you're well. You know, and if you can't get it,
Bring
do
them
it.
Christmas cookies
Yes,
this year and introduce
exactly.
yourself.
There you go. Now you've found the way to their
The
heart,
key
which
to
is
the key
food.
card is food.
right. Bring food.
That's what I'm
and-
going to do. That's a good idea.
Salty food.
Bring food, introduce yourself, and you know, and after a couple times, they'll figure out, you know, or bring an advocate, bring your father, bring, you know,
Your mother.
yeah, Guido, anybody, you know,
Guido.
A witness. A witness to listen.
do you have a hit me
Yeah.
on our
Yeah.
payroll?
say it.
Bring a-
Hi, I'm
bring a
the pod
hospital
set, and this is
bodyguard.
Guido, but
We don't want to upset Guido.
that's how we do it, you know. And I'm well, but I may come here and sick, and this is what, you know. And when they see you, like, oh yeah, it's that girl with the okay.
That's that girl that's
I'm
so hot.
totally going to do, yeah.
Yeah, well, so but that's a great point. You know, try to put these things in place before you have a catastrophe,
Right.
a crash and burn. You know, so you have to be proactive in that regard. Once you figured out what you have, and you've got past one wondering what I'm suffering from here, and you've got some kind of handle on it, kind of set up these things ahead of time because you're going to need them.
So one of the things I think we should talk about next is antidepressants and depression and anxiety and how that relates to POTS as a misdiagnosis and as a end result of being undiagnosed for 20 years.
Or if everybody's saying to you, "Gee, you don't
You're
look
crazy."
sick."
Yeah.
No, you look so good.
Your skin is flawless.
I know.
Yeah, I get that all the time.
That's because I've been on a diet of water.
Of course, yeah.
Also something that is widely used.
No, common treatment for the neuropathy. If we want to talk about small fiber for a moment, sure,
Is
because
the Cymbalta and the Lyrica.
well, all of the you mixed up a couple of categories there, but the drugs that are let's talk about neurotransmitter drugs, okay? So that would be the serotonin reuptake inhibitors and the norepinephrine SSRIs, SNRIs, generally categorized as antidepressants. Also, then some of the tricyclics like amitriptyline and nortriptyline and what have you fall into that category. Then, of course, there are the inhibitory neurotransmitter drugs like gabapentin or Neurontin and Lyrica. All of them have affect nerve transmission. That's what it's all about. In neuropathy, your brain is receiving signals of distress from the peripheral nerves, which are faulty because the nerves are acting faulty. And these drugs can alter neurotransmitter pathways and alleviate that. Sometimes they work dramatically well, I've seen. Sometimes it's just another wasted prescription, but often worth trying things that affect neurotransmitters because there's not too many other ways to shut down the signals the nerves are sending up to your brain. And so for some of the neuropathies, that's valuable. Sometimes in the vascular or whatever migraine is, and there's a lot of argument as to whether it's a blood vessel dilating or a functional brain disorder. They seem to help there. As you know or don't know, the major neurotransmitter of the gut is serotonin, so that altering serotonin with some of these drugs can make symptoms of irritable bowel or gastroparesis or just general maldigestion better. So they're often worth a try, and because again, they're not if we stop thinking about them as antidepressants and start thinking about them as neurotransmitter altering substances or drugs that affect neurotransmitters, we will broaden our horizon for what we use them for.
And what's interesting is that I think a lot of POTS patients, before they're well before they're diagnosed, end up on some kind of antidepressant or anti-anxiety medication and find that it does help. Even if they don't feel like they have depression or anxiety, it does help their symptoms, which can be so confusing. Because if you've been told that you're crazy and then you're on an antidepressant and you're better, well, that's only going to reinforce the idea that you were probably crazy. But
the cycle of panic and
Yeah.
anxiety, you know, the classic paradigm they use is it begins with a physical event.
Mm-hmm.
So you had a panic attack, and in the panic attack, you had a fast heart rate, and you were sweating, and your breathing was. So next time your heart goes a little bit fast, or your breathing seems a little bit short, that'll trigger the panic attack.
Yeah.
For no reason. So it becomes nonspecific. So we think of it as anxiety causing physical symptoms, but also often it's physical symptoms cause the state of anxiety. So
Right.
if you have inappropriate tachycardia or migraine or whatever you have, that can trigger whatever panic or anxiety is in the brain.
No, she has a question.
I have a quick question, doctor. I've been on trazodone for about 15 years for sleep
Trazodone,
and pain.
right?
Very, very helpful. And I went through the whole list of antidepressants for CFS years ago, and trazodone was the one that was the least harmful. However, my cardiologist may suggest, because I'm on midodrine, but may suggest a layering of an antidepressant now in addition to the trazodone. Now, I've heard the tricyclics are injurious to folks with POTS. Tricyclics are not recommended.
Is that what
Which-
Not necessarily. We've used them. Amitriptyline, typical nortriptyline, amitriptyline,
I guess what I'm asking is,
desipramine, those are.
what do you think with the combination of the
There's not-
traz,
there is-
and what would you suggest as the least?
I think trazodone, if you tolerate it, is fine. Remember, trazodone was, again,
Right.
introduced to be an antidepressant. You know, why did we stop using those drugs? Because they caused side effects. One of the main side effects of trazodone was sleepiness. So that's why we
Right.
use it for sleeping now.
It's good.
Yeah, we use it as a sleeping drug. Before, we used it as an antidepressant. That doesn't mean you can't ramp it up and get antidepressant activity out of that. You know, if it's a drug you tolerate and you take at bedtime and helps you sleep and you need something strictly for mood, it might be worthwhile exploring a higher dose of that before you went to something else, you know?
I think he's
Um,
not. I don't need it for mood. What he's talking about is
For
that
what
it would
purpose?
increase the blood pressure.
Increase your blood pressure?
It would. He's treating me for POTS, the cardiologist. That it would add. What are you saying? What role does antidepressant?
So in other words, you're going to
Treat like-
synergistically work with midodrine to increase
Yes.
your, not that I'm aware of.
Oh.
I mean, we know that there's mineralocorticoid drugs like Florinef and things.
Oh
that-
God, yeah.
yeah,
I'm very concerned about that, though.
Yeah, but I'm just saying, you know,
Yeah.
if you want to increase pressure specifically, I wanted to mention another drug. I think this might be a good time. I want everybody to just look at Vasculera, Vasculera. That's an over-the-counter plant derivative, which works great for toning up veins. It makes veins tone. So I've seen it work great in people with lower extremity swelling, what we call chronic venous insufficiency or lymphedema. It might help some POTS people out there. It's not going to help everybody, but I don't think it'll hurt you. It tones up the lower extremity vascular system.
It's an herb.
It's an herbal extract.
Who makes it?
Yes, it's
That's good info.
Seacoast that makes tablets of it.
well, it's here. I'll show you the. This is one of the things I.
In addition to
Copied.
Lidocaine?
Yeah, this would be totally. This is veins and trying to enhance venous return. Okay.
That's good info.
So yes, this is strictly. That's sort of what Minodrine is all about, but it would be an addition. Here's a. Oh, just went away. That's Vasculera. I don't know if you can see it.
And that's online?
Yeah, that's available. I think anywhere, Amazon, whatever.
Diosmiplex.
Diosmiplex, which is, if you read it, diosmin is the active substance that comes from the plant, and the plant has been shown to have venotonic properties. And like I said, I saw it in a case, an older man with very serious venous insufficiency. It really took his legs down from huge to very manageable, and I thought it was pretty amazing.
Awesome.
So when it works,
Cool, yeah.
Only
great
with
stuff.
swelling? Or if your legs don't swell, you could still use it?
well, we're talking about pooling, remember?
Pooling.
Yeah, we're talking about venous pooling,
Venous
so it might
insufficiency.
help for people who have, remember, in the POTS spectrum
Yeah.
or the whole dysautonomia thing, there's people who have pooling.
I do, yeah.
Right, and if you
Yeah.
have pooling and you're saying, well, how can I get that blood back up to my heart better? This might help. Can't hurt.
Someone had a question about how do you know if you're pooling if you're darker skinned?
That's a good question.
Well, it's really difficult to know. I mean, if you can stand long enough for you to start swelling a little
To
bit,
feel.
you'll know. But
Yeah.
a lot of people get, are gotten dizzy by then or have to sit down. But certainly, yes, your legs will start to feel tight because what's happening? I mean, certain volume of blood is going down to your leg, let's say, and less blood is coming back to your heart. So over time, there's a net increase in fluid volume in your leg. There's also, okay, go ahead.
No, you can finish your thought on that.
Well, I just go ahead. I don't see where
They
I
keep
had that.
asking about the use of Neurontin.
Okay, so Neurontin is an inhibitory neurotransmitter. It inhibits impulses in the spinal column, and therefore, and the central nervous system, of course, because originally, remember, it was introduced as an anti-seizure drug, which is now being used off-label as a neuropathy drug, and the use of Neurontin and by extension pregabalin or Lyrica is empiric, meaning they started using Neurontin for seizure patients, and they of course had patients come to you, and if you listen, they say, you know what, that tingling I had in my feet went away, or that burning pain I had at night, strangely is gone. And then they start paying attention and say, Neurontin might be good for that too, off-label, and therefore...
That's why there's a fibro mom who's asking if her POTSy daughter, could use it for her sleep problems.
It depends on if no, I think it's more of a neuropathy situation, what are you going to... Yeah, I mean,
Right.
but what are you going to... It's been used for
They use it.
fibromyalgia, but
Couple
it's not
patients
been
use it.
dramatically successful. However, Lyrica, which is a similar drug,
It helps
Yeah,
with
but
my
is the only
RMS.
drug that's actually FDA indicated for the treatment of fibromyalgia. It's only one drug that has that label indication. That's Lyrica. So if you have fibro and POTS, you might find, I have a fibromyalgia patient with CFIDS. She calls it meningitis
yeah.
and stuff.
Yeah.
ME.
ME.
And she thinks it's a miracle drug. It did wonders for her brain fog and for her fatigue and for achiness. But, it's a case-by-case thing.
A lot of people are shaking their heads no.
Well, but one person's miracle is always somebody
Yeah.
else's disaster.
Large weight
I mean,
gain
I
or
think that's a
something, yeah.
take-home message from
And
this,
I lost a lot of weight.
Oh, they left it?
See, she
No, I
gained
like
weight, she
gabapentin.
lost weight.
Oh, gabapentin?
There you go.
Gabapentin was the scariest. That was like
To
a
me, that was like being
Yeah,
hit in the
but-
head with a shovel.
But there's
Yeah,
lots of
exactly.
anecdotes, you know, anecdotal stuff is
But it
great.
took away
but-
every pain I had.
yeah. Put
But,
me
I
right
mean,
to
you're
bed.
Isn't that wonderful?
Yeah, but you're unconscious. you know.
Well, so I guess, like I said, you know,
Works
there's
great for sleeping.
everything works good for somebody,
Yeah.
and there's nothing that works for everybody, and that's just medicine in general.
You could write a song about that.
Yep,
Yeah.
that's the truth, but that's what I've learned. Many things I've learned, and that's one of the many things. Drugs interact in very strange ways. That's another thing I learned empirically. Tagamet and Zantac can make you, when I gave it to my grandmother, she described it as feeling like she just drank 2 scotches, she said.
Scratches?
Yep, made her demented, Zantac, but yet it's sold over the counter. you know.
Yeah.
I gave it to her for stomach upset. She said, I feel like I had 2 scotches. And I said, Graham, that's a classic. But, you know, and I gave it to another man who had a marvelously well-controlled grand mal seizure disorder, and he promptly had a seizure.
Oh.
Wow.
So because of the drug interaction, you know, it destabilized his anti-seizure meds. So you got to think about, if someone's going to add a drug, what's it doing to my whole package here, you know? I have a complicated regimen I'm on or non-regimen I'm on, and as things get added, you have to think about interactions.
All right, I'm moving you along because we got a lot to go.
Well, we could just come back another day.
We could.
Go ahead.
Okay, let's talk about, because we talked about this yesterday and I learned a lot. Ablations and pacemakers. What is the deal?
All right, so this comes up a lot. What is an ablation? What's a pacemaker? First off, I want to just a quickie on pacemakers. Pacemakers, obviously an implantable device that has a lead, goes down into the heart. Now it can go into the top of the heart, atrium, ventricle, or both atrium and ventricle, which is called biventricular pacing. Originally, pacemakers were meant to prevent the heart from going too slow. That was the whole shtick. And still to this day, we put a pacemaker in to prevent the heart from going too slow. That's something worth remembering. The modern day pacemakers can also make the heart go faster if they want to. But still, the most common reason to put in a pacemaker is to prevent the heart from going too slow. Why is that important? Let's say you have a person with inappropriate sinus tachycardia, and 1 minute they're going 40 beats a minute, and another minute they're going 120 beats a minute. Well, if I want to give a lot of drugs to slow down that 120 because they're extremely compromised by that, I might make the 40 go to 20, in which case they're in deep trouble. And if it really gets to that extreme, I might say at some point, we need a pacemaker to prevent the heart from going too slow. So let's say we set the pacemaker at 60 beats per minute. So no matter how much drug I give to slow down the fast heart rates now, the person will never go below 60. So I'm protected on the downside, and I can treat on the upside. Okay, similarly, if that sinus node is acting completely erratic and can't be controlled, and I want to go in there with a wire and burn it or ablate it, then something has to take over as the heart's pacemaker. Because if the heart's own pacemaker, the sinus node, cannot be trusted to run the show, and we're going to ablate it, then we have to have a pacemaker that's going to take over. And the pacemaker will set the rate below which the heart cannot go. And the modern day pacemakers, which are demand pacemakers, can also increase the heart rate if you want to do something. So if you want to run up a flight of stairs or play baseball or something, the pacemaker can speed up your heart too.
So if you're a POTS patient and you've been through everything, I mean, you've been through all the beta blockers, you've done the cardiac rehab, you have
Ivabradine, failure.
you've done it all and it's all failed, is that when you get an ablation?
Well, if you have those completely uncontrollable heart rates, you might have to do that someday.
And then
Right.
if you get an ablation, you have to get a pacemaker.
Right. If you know, the heart has Just to reiterate for a moment, your heart has a hierarchy of pacemakers. All right, the top of the heart is the sinus node. That's the fastest. That has an intrinsic rate normally of about 70. Then you have the atrioventricular node. That operates at about 50. Then you have pacemakers within the ventricles, but they only fire at about 20 or 30 beats a minute. So if you ablate this one, you can't rely on this one to just go 50 beats a minute, and this one won't make it. So if you're going to destroy the sinus node, you're going to need a pacemaker. But sometimes we have to resort to that. And many times we have to resort to ablating the atrioventricular pathway, the connection between the upper and lower chambers of the heart, because of uncontrollable upper heart activity. We just stop the connection, put in a pacemaker, and control the heart rate that way. But those are all extreme examples. Now, we also talked yesterday, let me add, we talked about other kinds of supraventricular tachycardia, which can be treated with ablation and which are cured, and that's the end of it. Those are the so-called reentrant type tachycardias, where there's a normal pathway, sinus node, conduction system down to the ventricle, and there's a re-entry pathway whereby the impulse re-enters the atria and stimulates a circuitous tachycardia. We call those reentrant tachycardias. That can be ablated quite nicely. We can interrupt that reentrant pathway and you just have your normal function. So you will see many people who have supraventricular tachycardias that have ablations and are fine. They don't need pacemakers. They just have normal hearts again. But if your sinus node is acting haywire and no drug can control it,
And that's called inappropriate sinus tachycardia, right?
I think that would come under the heading of yes. Actually, we call it more commonly sick sinus syndrome, triple S, which I referred to yesterday, which means a sinus node which is acting erratically. And sick sinus can mean too slow, too fast. And when you have a person who's always going too slow, that's easy. You put in a pacemaker and you prevent that. If they're always going too fast, you can deal with that. But when they're going too slow and too fast, it's really hard to calibrate your drug exactly so that they never go too slow, but they never go too fast. And sometimes with sick sinus syndrome, we just have to end up ablating the node, putting in a pacemaker, or ablating the connection, putting in a pacemaker or something to just control it. And that's a very common situation.
So depressing.
I know, I'm so depressed after hearing that.
The technology is there, though. I'll tell you what,
She is a pacemaker.
it's wonderful,
I
right?
had 3 ablations.
You've had 3 ablations.
And I was just told I may need a 4th.
Can you-
And they treated
What are
me.
your ablations for? What is your
I was
diagnosis?
told first it was for sinus nodal reentrant tachycardia.
Okay, SNRT, which is what we just talked
And
about.
then I was just told recently my IST is so out of control, they're not even sure ivabradine would help because I'm hitting 30 and 40, and then my pacemaker is not always kicking in to bring me up, but then my natural pacemaker is still bringing me up over 160, 170.
Which is what I just
Holy
described,
But
right?
then I'm also having atrial tachycardia and episodes of AFib that my pacemaker is recording.
So did they
But
ever?
you look good. Yeah, thanks.
Did they ever
Great
ablate?
skin.
A lot.
They never ablated your AV node, in other words, not yet.
As far as I know, they did a complete ablation.
No, what they
twice.
ablated the first time was the reentrant pathway.
I
Okay.
think so, the first time, and then the next 2, the second one they did it again, and then the third one they did a complete ablation because they froze
Of
the
what,
phrenic
though?
nerve.
Yeah.
They didn't tell me. 'Cause
Okay.
They froze the phrenic nerve.
Yeah, it's complicated, but so this is a complicated topic because of all the things you just described, and there's many, many different variations and things we ablate. There are even areas within the atrium that set up arrhythmias like atrial fibrillation and paroxysmal atrial tachycardias that can be ablated and then it goes away. So sometimes we can actually cure things like atrial fibrillation and other kinds of atrial tachycardias. But when the sinus node is acting crazy, Sometimes there's no other way.
So the technical term would be you're up Schitt's Creek.
Yep.
Up Schitt's Creek. That's
Well,
USC
So then what is the bottom line then?
on Twitter. I'm USC.
So what is then your future direction?
My electrophysiologist down here was talking about a cervical sympathectomy,
Cervical sympathectomy, right?
but my electrophysiologist at Johns Hopkins, who I run everything by
Yeah.
because it's Johns Hopkins,
That's pretty.
pretty much said, let's just see how the next couple months go with how your pacemaker goes, how your heart goes. He monitors everything now through my pacemaker machine, my cardiac messenger, everything goes to him directly.
And how is it going? Can you tell?
So far, I'm still having the atrial tachycardia episodes 7 to 8 times a month, over 170 beats a minute.
And how long does it last?
Sometimes 3 to 4 minutes at a time.
3 to 4 minutes. And how do you feel during it?
They're doubling me over. It feels like a heart attack.
Okay. All right. So that's pretty symptomatic. That's pretty dramatic.
So right
And that's
now,
pretty
yeah,
extreme.
So
So
he's starting to consider another ablation, which will be my 4th. But on top of that, I have everything else going on. So.
well, eventually they're going to try to just ablate your AV node, which is the final solution. Yeah, I mean you can't go back from that, but you have a pacemaker and you live with it.
Is it possible your body to reject the pacemaker? Because I know my bottom.
Question is it possible for your body to reject the pacemaker?
Oh, absolutely. It's a foreign.
Makes me so sick.
It's a foreign body, so you're subject to foreign body things. I've seen pacemaker leads come loose. I've seen them get fibrotic and lose connection. There's lots of things can happen with a pacemaker, but by and large, it's a good thing. Thank God they exist, and thank God the technology is so much better than it used to be. I will say they're dramatically smaller, better, faster, smarter, and will continue to get that way. Let's face it. What can we look forward to? The next 5 or 10 years, a pacemaker, like every other technology, it'll be no bigger than a dime, and maybe you'll swallow it or something. But so I think that's an area of a lot of hope, because your heart is not acting properly for whatever reason, and technology is coming along dramatically there. So that's one area where my 30 years of practice I've seen phenomenal improvement.
So do we want to maybe use some of this for the next meeting and answer some of their questions?
Sure, we can take a couple of questions. I think we're all about maxed out anyway.
All right, so Dysautonomia doc stated that I may not have POTS due to other prominence of hypertensive episodes, but rather labile autonomic control with increased heart rate and BP. What do you think of that?
More labels, right? Labile and labels.
Labile.
Labile means, of course, it's fluctuating, up and down, up 1 minute, down the next, and so it's constantly changing. People like to make up acronyms, labels, USC, things like we just said. That seems to be the pigeonholing trend. Why don't we just say she has dysautonomia or autonomic neuropathy or dysfunction? Why all those different little pigeonholes? Are we going to develop a specific treatment for every 50 different pigeonholes, or are we going to take a unified approach? I'm a unified approach person, so.
Dysautonomia treatment is symptomatic. It's
right now it's
treating,
symptomatic,
so.
right? Exactly. We're treating the symptoms and signs. We're not treating causes yet. Hopefully we'll get to that. We'll get to genetic abnormalities of norepinephrine transport and other, receptor antibody problems, and that's what the folks at all these centers are trying to get to. And as fast as they think things up, we're trying to incorporate them in everyday practice so that people can live better. And so, another question?
Could it be viral?
What?
Someone has a very high viral load, EBV, HHV6A, Coxsackie, high viral load from originating from mono. I mean, which comes first, the chicken or the egg? Is it the viral that causes the POTS, or was it the POTS that aggravate,
words-
increases? Yeah.
Yeah, we all know that POTS commonly follows viral infections, trauma, childbirth, all kinds of immune
Car
system
crashes,
disruptions. Right, car crash.
Mono.
Everything where inflammatory and immune systems are activated. And is it an innocent bystander? Sure, I'm sure in some cases it is. In other words, there are plenty of medical precedents for. We all have a sort of a unique genetic makeup to our cells. If that cell and an invader, let's say a virus, come in and have some close similarities, maybe our immune system gets confused and suddenly starts attacking ourself as other. That's a commonly described medical situation. There's
Causing
plenty of
POTS?
precedents for that.
Causing
Anything,
Or ag-
causing
or
all
aggravating
kinds of illnesses.
orthostatic intolerance.
Autoimmune disorders in general,
Mhm.
lupus, rheumatoid arthritis, POTS,
CFS.
dysautonomia, CFID, thyroiditis. I mean, you name the autoimmune disorder, and I will tell you that there are cases where it was triggered by the invasion of something that looked like self, confused the immune system, and the immune system began to attack the person's own tissues, and therefore it developed or segued into an autoimmune disorder. And that could be POTS, that could be, like I said, rheumatoid. It could be all kinds of things. I've seen people develop rheumatoid arthritis after knee replacement surgery. They just cut the tissues all up, and in the healing process, the immune system gets confused and
Yeah.
starts attacking it as foreign. So can it follow a viral or bacterial infection? Absolutely. Is that the only way it can happen? I doubt it. There must be other things that because a lot of these viruses remain resident in your body for life, like the chickenpox virus and the EB virus. And so what are they doing in there, and how are they, that their RNA and DNA are incorporating themselves in our own cellular nuclear DNA? And how does that change the expression of? So if you have a virus with its DNA and it gets into your cells, and that DNA becomes part of your DNA, and then a protein is elaborated to the cell surface that's now sort of a hybrid between viral and yours, and the immune system decides, wow, that's not part of our spectrum here, and starts attacking. That's probably what triggers a lot of this stuff,
All right. So,
So
next
we
question.
have to figure out how to control that. Okay, go ahead.
My daughter has a problem with her body temperature. Daily fevers at night mostly, and terrible sweating during the night while sleeping. Been dehydrated 6 times and had to go to the emergency room for IVs since June. Anything we can do to control this? Advil is not working to keep her fever down. All tests are negative. Mayo gave diagnosis of dysautonomia. Don't have appointment with specialists at Columbia until January. Very hard to get a doctor to see her.
So now we're talking about central temperature regulation. Automatic functions of the central nervous system, which are primarily located in the pons in the lower midbrain, hindbrain. Those are ancient centers that control things like breathing while you're sleeping, blood pressure while you're sleeping, temperature. I've always been completely amazed by things like temperature. How does your body maintain exactly the same number all the time, wherever you go, whatever you eat, whatever? 98.6. This poor person has central temperature dysregulation.
My temperature at night can reach up to 103 degrees
Oh my God.
every single night.
So how often? So she's saying her temperature does this too, and how many years has it been doing that?
For about a year and a half now.
About a year and a half.
99 to 100 during the day. We actually right now have my own personal unit, AC unit in my room.
Okay, so you've got an AC in your room.
I've had to get a personal AC in my
Right.
room. I sleep with ice packs.
Has anything else worked? Any of the drugs? Any of the nothing?
Nothing has worked.
And what did that come out of? Why did it start?
No one knows.
There you go. There's your
I can't
answer.
tell
Isn't that hormonal?
temperature. The only way I can tell temperature is a hippo, like a baby back hippo thermometer. And if I start itching, it's too cold, or it's too hot. If I start seizing, it's too cold. That's the only way I know temperature. Like outside, if I start itching,
So
know
I
it's
guess the
hot.
one question, she says she's not aware of being hot or cold, but she is overheating or underheating. Is this person's daughter aware of being too hot or too cold, or
I don't get night sweats or anything. Like that's the only thing that helps.
this
Very much
this young
so.
girl is
Very much
dehydrating
so.
because she's evaporating sweat so fast?
I'm wondering, any relation to the cycle? I don't know how old the
So the
daughter is.
question
Relation
is-
to the cycle?
Yeah, it's
hormones?
it's a complicated question because we
Yeah.
don't know if she's skinny, if she's overweight, if she's PCOS, if she's, we talked a little bit about polycystic ovaries,
Yeah.
the menstrual cycle, et cetera, et
There
cetera.
is, if she's hotter at night, there is a special bed that is made that we found. I'm trying to get it now.
Right, a cooling bed.
It's a
Yeah,
Right.
or
cooling
pillows too.
And there's
She's saying
pillows.
there's cooling beds and
It's
cooling
called the chili
pillows.
pad.
So in other words,
chili
we're-
pad or the chillo.
We're talking about treating the symptoms, and this person would like to know what can they do, what's causing it, and what can I do to treat the
Wow.
cause.
She's saying that her daughter is overweight, layers bed with towels, goes through 3 to 4 a night.
So she's overweight, and how old is she?
How old is your daughter? 36.
Okay, so she's
Okay, so she's
perimenopausal.
36. She's overweight. Yeah, she's somewhere in between, right?
Mhm,
Menarche and menopause.
mhm.
So, and we don't know what her, we don't know if she takes birth. I mean, it's a complicated case. We don't know if she's got polycystic ovaries. We don't know if she's got intracranial hypertension, which is common in overweight females. We touched on what we used to call pseudotumor cerebri when I was in residency, is now called benign intracranial hypertension. Common, again, like I said, in overweight younger females, so she would be a good example. So I would have to ask, does she have benign intracranial hypertension? That would be something that the doctors can look at, and that
She's been
may
on
be,
birth control for years.
yeah,
For birth control or for
for menstrual irregularity, or
Yeah.
is it? And does she have diabetes? Of course, she has diabetes, prediabetes, or hypertension, or prehypertension. And that's something we never even touched on today. But the sympathetic nervous system feeds into all of those things.
for
and-
regularity issues with no diabetes.
Okay, but I did want to mention that part of the research that was we talked about yesterday, and you almost punched me out for, dysautonomias and sympathetic nervous system dysfunction has a very high concordance with diabetes, hypertension, heart disease later in life. One of the articles said, if you have sympathetic nervous system dysfunction in your 20s, you have about a 60% chance of going on to diabetes, which is pretty dramatic.
Yeah.
Similarly, hypertension. I mean, this is
It's all
evolving.
good news today.
Yeah, well, I just want everybody to sort of be aware of this stuff. No,
No,
this
no,
is
it is. It's
advanced
important,
class. This
yeah.
is not like, I mean, you're big girls. You have to
So
can't go into denial. You have to go into
you
proactivity.
mentioned PCOS, and I see it's in here, and I don't want to bring up a topic if we're going to talk about it. I was diagnosed with endometriosis.
We're talking about, she's asking about PCOS, PCOS, polycystic ovary syndrome.
So I was diagnosed with endometriosis at 14.
Right.
Is there a tie-in to that and dysautonomia as well?
Well, again, remember, absolutely. Answer is yes. Is metabolic syndrome associated with PCOS? Yes. Is endometriosis? Yes. Is insulin resistance, which is a feature of PCOS and endometriosis, is that tied into dysautonomia? Absolutely. And that's where I was going with a lot of the articles that I cited to her yesterday. There's a lot of research now linking various states of sympathetic nervous system dysfunction and insulin dysregulation, insulin resistance, and problems like that. So the answer is yes, absolutely. Can't talk to you right now. So I hope no one's dying. So okay, so we've got a lot of material we covered and a lot of material for
next
future.
time. Yeah, I'm sorry we didn't get to go over everything. But we're
Well, there's
running.
tons we didn't even
Yeah,
begin to
we
touch
have
on,
like
but
10 other slides to go through, but we are running to about.
we could do plenty of these
Yeah.
advanced class webinars. It's not that difficult.
No, not at all. But we did cover an hour and a half of material, and you can always go ahead.
I have one more question. Sorry, I was just told recently, like 4 days ago, I had scoliosis.
Okay.
Is that
She was told she has scoliosis.
is that something normal with dysautonomia, or is that completely?
It's not normal with dysautonomia, but maybe normal with joint hypermobility or Ehlers-Danlos or connective tissue disorder, or et cetera, et cetera, et cetera. Because let's face it, it's you're talking about the spine and discs and et cetera, et cetera. So there may be some laxity there, and maybe that's your manifestation of.
I have a lot of manifestations.
Well, you said your child might have Ehlers-Danlos or joint hypermobility, and maybe that's your thing, scoliosis.
Just so everyone is aware, if you go to www.santamariamedicine.com, you'll be able to look at our resources page, which had a lot of background information on all the things we talked about today, scientific studies that we put up. There's also a whole section on dysautonomia, and we've done a couple of blogs answering questions like shortness of breath and, talking about medications. So
We'll add to it too.
Yeah.
Some of the past webinars are there. So
yes,
they
you can also go
listen to some of the more basic stuff too.
Yeah, and we'll have this posted online this week as an MP3, and we'll also have the slides from the PowerPoint posted online, so you'll be able to see everything. And
they can also get it on YouTube, right, and then chop it into segments. We talked about making little snippets of.
If they feel it.
You.
Yeah, no, yeah.
We talked about that,
Yeah.
as a way to show somebody what I've got, or a little snippet on my.
But we are also working on printout, downloadable
yes,
documents.
handouts too, which are.
Yeah,
which
that'll
are
be great
useful,
for
yeah.
giving to your doctors and giving to the emergency room doctors to help you in a pinch. And you can always email Dr. Santa Maria at potsresearchproject@yahoo.com, where he'll be able to read and answer your questions, or we'll be if they're not answered, then we're collecting them for the next webinar or podcast.
And one of the questions we talked about this week on that site was POTS, diabetes, sympathetic nervous system, and weight loss, and why is it so hard to lose weight for some people now? Obviously, that's not everybody, but nothing is everybody. But a lot of patients have difficulty losing weight and are frustrated by it. It goes back to the sympathetic nervous system again. We know that inhibiting it with beta blockers can cause weight gain, and we also know that the POTS patients, dysautonomia patients, don't have the sympathetic nervous system blast or discharge that normally occurs after eating, which helps burn up the food. So that was another line of research we talked about. We'll continue to talk about. Okay.
He's got calls to take, so thank you everyone who
Hello,
tuned in.
Thank you,
and
doctor.
Yeah.
Thank you so much.
Hello. Yeah.
Fun.
Yeah, go ahead, Pat.